I'm glad to be a part of this instruction course, and the topic I'll be giving you is posterior segment complications after refractive surgery. There are certain pertinent questions that we have to deal with. Firstly, does having a refractive procedure predispose to retinal disease? And some of the retinal complications that you will see after a refractive procedure include the formation of retinal tears, retinal detachment, presence of retinal hemorrhages and macular hemorrhages, development of a macular fluid, serous macular detachment, the presence of a choroidal neovascular membrane, and even reactivation of ocular toxoplasmosis has been described. Now, the most ominous of these could be definitely the occurrence of retinal detachment. There are multiple studies that have happened which make the incidence, as you can see, from as high as 0.25% by a large study by various models. And the development of retinal tears and RD has been noted 14 hours, as close to 14 hours after LASIK surgery, but a large study placed the common occurrence within 3 months. The presence of retinal detachment has been described after radiotherapy, refractive procedures, refractive lens exchange, and phakic IOLs. The study by Ruiz Moreno could be a very high incidence at 4.8% after phakic IOLs, but a much larger study by the Arivalo et al. Group with low incidence of RD after implantation of ICLs at 0.7%, and in one particular group of lenses at 0%. This is what we have to realize, is that the yearly incidence of detachments has been estimated to range from 0.015 to 0.075 in 10 population. The Moreno et al. Group had pegged in their study at 0.36% with a mean occurrence of retinal detachment at 34.6 after studying over 5,000 patients. The Arivalo et al. Study has placed the incidence in a previous study of theirs at 0.04 to 0.05%, within the range that we mentioned for the general population. This was a study of nearly 12,000 patients. And there was a yearly increase in the incidence, and which became nearly 0.2% after 10 years after the procedure. So, interesting things in this particular study was that the average age of retinal detachment after LASIK was nearly 42 years. A slightly elderly age group than the typical age group for this 12 months. And what was also interesting that no patient developed detachment who had previous prophylactic laser photoretinal lesions. The total the incidence of all retinal pathology in that study was 0.05 to 0.19%. So it is seen that the incidence of retinal detachment after refractive surgery is generally much lower than the general population numbers. And you can probably attribute this to all LASIK patients having good direct fundoscopic external depression, followed by pre-treatment of many of these for this. So, though there are no specific indications as to whether we should treat LASIK patients different from any other person who wants to have peripheral agents. There is no hard evidence to say that whether prophylactic treatment is indicated, given the general tendency for myopes and patients with high refractive errors to have retinal pathology. It might be prudent to treat these meticulously. So, retinal detachment happening after lens-based refractive procedures is a slightly different with much higher rates, ranging from 1.5% to 3.28% in some studies after lens-based refractive procedure. So the question comes, does the management of retinal pathology alter the backdrop of such refractive surgery? So the intraoperative management issues we could be dealing with is the visualization, will the visualization be affected, whether the implanted lens would slip out of its position by the somewhat vigorous maneuvers that we believe that the two surgeons will do, and whether it is mandatory to remove the implanted lenses during surgery, and we'll discuss some other complications also. So I'm just going to start with this video. So this particular patient who had a retinal detachment, we started off by implanting, putting around a bell couple, which went on well. Why I say went on well is that after we could see that the ICL is still in position after the bell couple is placed, it hasn't slipped out or hasn't caused any issues. So this particular patient had a giant retinal tear after trauma, after a 45-year-old was implanted. You can see the large leaflets of the GRP, and we proceeded with the vitrectomy, and you can see the edges of the GRP. It's a significant thing. So the vitrectomy procedure after the vitrectomy was completed. You can see the detached retina, and the anterior leaflet of the retina, which is freehand, was removed. The edge of the GRP was cauterized marked, as you can see here. PFCL is now being injected to flatten the retina. It's a small PFCL bubbles. As the PFCL increases, and you can see as the procedure increases, as the PFCL bubble increases, the retina is being pushed flat. So far, the visualization has held good, and the presence of the ICL has not caused any difficulty so far. So once the PFCL has reached the maximum, you can see the laser being applied to the edge of the GRP. Laser marks the laser goes all around, and then I'm putting a really good 3 or 4 layer lasers to hold on the retina. And once the laser is complete, we'll just try out the edges of the horns of the GRP just for additional security. So that's the cryo marks coming to the edges of the GRP, the horns of the GRP. And there is no problems with the integration of the blood resistance, with any problem with the ICL position or anything. And after now, you can see the air, fluid air exchange is being done. PFCL is being removed. And after the PFCL is, the last amount of the PFCL has just been removed. Now oil is being injected. And the ICL held through all the procedures, including the bell couple, the invitation, some of the complications that can happen even in the post-operative period is AC shallowing, especially if you use tamponade with oil, displacement of the lens can happen. This particular patient we operated developed anterior ischemia because of a high volt ICL, the presence of a buckle, and also the presence of oil inside, probably. So we hypothesize that it caused anterior ischemia for this patient. Cataract formation and glaucoma are also complications. So the last question being, what are the precautions the retina surgeon can take to ensure a good and accidental outcome from the retina point of view and accidental refractive outcome? That is that we do as minimal a job as possible, cryopexy, pneumatic retinopexy when possible, and vitrectomy when essential. Avoid the use of a scleral band or any procedure that tends to change the shape of the eye length of the blade. An option that if you have to use a scleral band would be to remove it after a couple of months before the elongation of the blade comes upon picture. Other retinal pathologies that can happen due to the increased IOP by activation of the section could be the development of lac attacks and macular hemorrhage and CMD and IOPs. The same would happen in patients with angioid streaks and connective ruptures if they undergo LASIK. Stage 1 macular holes can clearly proceed to full thickness macular during the maneuvers of the procedure. To summarize, patients undergoing refractive procedures require retinal evaluation thoroughly, treatment of all peripheral lesions. Older patients may be more susceptible to develop retinal detachment, and the incidence for retinal detachment decreases with time, but generally, the incidence is not much more higher than that of the incidence of retinal complications. The surgical management has to be always subtle to avoid maneuvers that change the refractive surface. IC18 removal may not be necessary or mandatory and probably can work around these. Visualization may be hampered by cataract formation and flap displacement. Issues with tamponade have to be anticipated, like shallow BBC, and posterior complications may include cataract formation and antecedents. Thank you very much for your patience.